Hello, thank you so much for joining us today for our GHAPP MASLD MASH Community Network. As Jennifer said, I'm Kelly Smeester. I'm a physician assistant. I am from South Denver Gastroenterology. And you can use this QR code to record your attendance for today's meeting. So today we'll be discussing the MASLD pharmacology. We're going to discuss the currently available treatments for dysmetabolic management, and specifically the goals of controlling obesity, reducing cardiovascular disease risk, and targeting NASH. So as we think about obesity, our goal is weight loss, and this can be, of course, achieved through lifestyle modifications with diet and physical activity. We might also consider weight loss medications, including the GLP-1 receptor agonist and the dual agonist GLP-GIP receptor agonist, and possibly bariatric surgery for these patients. We all know that a 7 to 10% goal of weight loss can help reduce fibrosis in our liver disease patients. However, this is difficult to achieve, and so we'll talk about some other ways we can help with fibrosis as we move forward. Secondly, we want to reduce cardiovascular risk. So we want to treat type 2 diabetes and cardiovascular risk factors. So we want to address hypoglycemia. Again, GLP-1s and or SGLT2s may be something we will use here. Hypertension and dyslipidemia need to be addressed as well. It's important to keep in mind that the NAFLD does not increase the risk of drug-induced statin liver injury. So we can continue to prescribe statins for our patients, and we'll discuss that in greater detail later on. And lastly, we want to focus on some liver-directed treatment for targeting NASH, and we'll discuss vitamin E, how that can be used in patients, Pioglitazone, and Resmetirom. So starting with the GLP-1 receptor agonists, these are endogenous hormones secreted after food ingestion. They stimulate the glucose-dependent insulin secretion, help suppress glucagon, delay gastric emptying, and directly act on the hypothalamus to promote satiety and reduce energy intake. So the GLP-1 receptor agonists are analogs of this gut-derived incretin hormone, and they mimic the actions of the endogenous hormone. And they are intended to lower blood glucose and cause weight loss. So we will discuss how they can be used in hepatology practice. So there was a trial called the Essence trial where semaglutide was studied at 2.4 milligrams once weekly, and it was found to meet the primary histological endpoints at 72 weeks, showing significant MASH resolution without worsening fibrosis and significant improvement in liver fibrosis without worsening MASH. So based on these results, it's advisable to consider administering a GLP-1 for overweight MASLD patients, with a higher priority given to those with MASH or fibrosis. And for our lean MASH patients, this might not be the best option just because we know it'll induce a significant amount of weight loss, and that may not be appropriate for that type of patient. As GI providers, we know that there are a lot of GI-related side effects to the GLP-1s, and one of those specifically is delayed gastric emptying, which then can increase the risk of aspiration when they are undergoing anesthesia. So it's generally recommended that GLP-1s be held for 7 days prior to a GI procedure, such as an EGD or a colonoscopy, because of that increased risk of aspiration. If a patient has taken their dose within that 7-day time frame, it is recommended that they cancel and reschedule their procedure. Next, we're going to look at vitamin E. The dosage for this is 800 international units given daily. It's indicated for non-diabetic MASH patients without cirrhosis. And the mechanism here is that it is an antioxidant and has properties of reducing oxidative stress in the liver cells. So a specific study that was done to evaluate this is called the PIVENS trial. It was a landmark study showing vitamin E improved liver histology in non-diabetic patients with NAFLD. Approximately 43% of patients showed histological improvements, and this included hepatic steatosis reduction and reduction in lobular inflammation. But there were some limitations to this trial. Certainly not all patients responded, only about half or less than half showed improvement, and it cannot be used in hypertensive or diabetic patients because this may increase the risk of heart failure. There are also some risks with bleeding, which we'll discuss in a moment. So because of these limitations, the guidelines are somewhat mixed. The 2023 AASLD guidelines suggest vitamin D may improve NASH in non-diabetic individuals, while the 2024 EASL, ESAD, and ESAO guidelines do not recommend it as a MASH therapy due to the limited efficacy. Specifically, it was not as helpful in reducing fibrosis and those potential risks. And some of these risks include, as I mentioned, bleeding, especially if patients are already on a blood thinner, and it can cause potentially hemorrhagic stroke, which is a major concern. Also prostate cancer concerns. And so in general, we want to be very cautious when we're considering this medication and be sure to discuss the long-term effects with our patients. Next, we'll discuss Pioglitazone. This is dosed in 30 to 45 milligrams daily for MASH patients with or without type 2 diabetes. It was also studied with the PIVENS trial, and it showed no benefit over placebo for the primary outcome in improving histological features of MASH. However, there were some benefits observed for the secondary outcomes in the improvement of cardiovascular disease risk. So there are some safety considerations that are really important. Potential risks of weight gain, which is certainly not desirable in our MASH patients. Edema, bone fractures, especially in women. So we want to avoid this in women who maybe have a history of osteopenia or osteoporosis, and a possible association with increased risk of bladder cancer. So certainly we need to be careful about patient selection and monitoring. And lastly, we have Resmetirom. This is our newest medication, recently approved in March of 2024. It was approved by the FDA in conjunction with diet and exercise for the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis with moderate to advanced liver fibrosis. So these are patients with F2 to F3 fibrosis. So Resmetirom received the accelerated approval by the FDA, and this is a pathway that allows for earlier approval of medications to address an unmet medical need. It is a thyroid hormone receptor beta agonist, and it selectively binds to and activates the thyroid hormone receptor beta in the liver. And we'll talk about this. So we'll review the physiology between the thyroid and the liver. So the hypothalamus pituitary axis promotes the production of TSH, which then causes the thyroid to produce thyroid hormone, T4, which is converted into T3. This then is uptaken by various tissues throughout the body. Primarily, most tissues have the thyroid hormone receptor alpha in the brain and the heart, for example. But the thyroid hormone receptor beta is primarily expressed in the hepatocytes. And it has been found in MASH that the impairment of this thyroid hormone receptor beta can cause mitochondrial dysfunction, which then in turn causes inflammation and lipid accumulation. This leads to hepatocyte damage and fibrosis. So the goal of Resmetirom, by activating and stimulating the thyroid hormone receptor beta, is to increase the signaling of this receptor, which influences gene expression related to lipid metabolism. It improves the fatty acid oxidation, improves cholesterol conversion to bile acids. It reduces lipotoxicity by reducing hepatic fat accumulation and reduces inflammation. So it also helps kind of reorganize those mitochondria to be healthier so that they can do all of these actions. So the MAESTRO-NASH trial is the ongoing phase 3 randomized controlled trial of Resmetirom in NASH with our liver fibrosis patients. So this trial studied adults with biopsy-confirmed NASH in a fibrosis stage of F1B, F2, or F3. So nearly 1,000 patients were randomly assigned to one of three groups, either once daily resmetirom 80 milligrams, resmetirom 100 milligrams, or placebo. And the two primary endpoints that they were looking to achieve at 52 weeks were NASH resolution, including a reduction in the NAFLD score by greater than 2 points with no worsening of fibrosis, and secondly, an improvement or reduction in fibrosis by at least one stage with no worsening of the NASH. I'll comment on what the NAFLD activity score is. It is a score calculated by using results from a liver biopsy. It's looking at steatosis grade, lobular inflammation, and liver cell injury. And so each of these patients underwent a liver biopsy to confirm that the reduction in fibrosis was observed. Looking at this phase 3 safety data, diarrhea and nausea were the most frequent side effects noted with resmetirom, and they were more common in both the 80 milligram and 100 milligram dose when compared to placebo. Thankfully, the incidence of severe adverse effects was similar across all trial groups and was relatively low. So again, looking at these primary endpoints, both resmetirom 80 milligrams and 100 milligrams were superior to placebo with respect to NASH resolution, which we see there on the left, and improvement in liver fibrosis with no worsening of NAFLD activity score, which is represented on the right. In both scenarios, you can see that the 100 milligram dose was superior to the 80 milligram dose. It's just found that the 100 milligram dose has greater efficacy in patients who have a higher weight. So it is recommended to prescribe 80 milligrams for patients less than 100 kilograms, so that's around 220 pounds, and to prescribe the 100 milligram dose for patients greater than 100 kilograms. So as we consider practical considerations for managing MASH with resmetirom, we certainly need to choose the ideal patients for treatment. Again, these are adults with non-cirrhotic, we want to emphasize that, non-cirrhotic MASH. Patients with moderate to advanced liver fibrosis, they must fall in that category of stage F2 to F3. And reminding our patients that this is only improved in conjunction with diet and exercise. We want to encourage them to continue to work on lifestyle modifications. Additional considerations are drug-drug interactions. So the medications are divided out here. You can see the different categories. There's medications to avoid on the left here that should not be administered with resmetirom. We have in the middle medications that are tolerated, but they need a resmetirom dose reduction. On the right, we have medications at increased risk of exposure due to resmetirom. So these medications need to have a reduced dosage. And you'll see here is Pioglitazone, when we just discussed that one is a max of 15 milligrams. And lastly, we have our maximum statin doses. So these are listed here, and resmetirom and statins can be administered together. However, we want to make sure that we do not exceed these doses listed of the statins, because the combination can increase adverse statin-induced side effects. And so by trying to reduce those, we will keep these statin doses at these maximum levels. So ongoing considerations, we need to determine the duration of treatment and monitoring. So the MAESTRO-NASH trial is ongoing. So this is something that is currently being evaluated. We need to determine when and how to restage fibrosis with a non-invasive testing. So we could do this with the VCTE, which is vibration-controlled transient elastography, also known as the FibroScan, which gives a measure of not only the fibrosis score, but also the CAP, which is the controlled attenuation parameter, which shows a measure of hepatic steatosis. We could also consider using the MRI-PDFF, which measures fibrosis, or the ELF score, Enhanced Liver Fibrosis Score, which is a serum biomarker, which helps characterize the degree of fibrosis. So expert panels are continuing to work on these cut points and how often we need to do testing. Certainly questions remain. So widespread resmetirom use will depend on insurance coverage. And that will remain one of the factors, certainly, for being able to use this medication. Also, as we said, the timing for staging and monitoring of this medication is to be determined. We need to determine duration of treatment recommendations and when to discontinue the treatment. And it's very exciting because there are multiple agents currently in clinical trials, and so we will have more options in the future to help treat this patient population. So in conclusion, if you would like to visit the GHAPP MASLD Community Network to view MASH disease state education, and you can review the Rezdiffra promotional program. Thank you so much for joining us. I would be happy to answer any questions.